Get what we need.
And this is this week's Closet Classic.
Hi, welcome to Burlington Magazine. I'm Tony Inverso. If you or anyone you know has ever been affected by something commonly known as the winter blues, there's some good news out here for you. There have been recent studies that show that the winter blues may actually be a medical problem that is very, very treatable. And to talk about that with us today is our guest, Dr. Janis Anderson. Dr. Anderson has a PhD in psychology from Vanderbilt University and has done postdoctoral work at the University of Rochester. Presently, she is director of the SAD clinic at Brigham and Women's Hospital. Dr. Anderson, thank you for being with us today. Maybe you could explain briefly to us what seasonal affective disorder is.
The name, of course, seasonal, comes because this is a condition that comes in a certain season every year. And affective is a word that we use that refers to mood disorders. Sometimes we talk about disorders of affect that include depressions or anxiety. So a seasonal affective disorder, in this case, involves a kind of depression that happens on a regular basis in certain seasons of the year.
Now, this seasonal affective disorder, or SAD, as it's commonly referred to, for what percentage of SAD patients is the depression considered clinical depression?
Well, I would say the estimates are in this part of the country, because it actually changes as you go farther closer to or away from the equator. But in this part of the country, about a quarter of the population will report certain kinds of changes in the winter that are consistent with the picture that we see in SAD. But only about 5% really report symptoms that are of a severity that we would say was clinical depression. So it may be that about 1 in 5 of the SAD people has it severe enough so that you would consider it clinical depression.
What is the distinction? We might make this distinction for our audience, the distinction between just being depressed, which happens to everyone, and clinical depression.
It's true. Sometimes it can be confusing because the term depression gets used in so many different ways. It can just be a way that people talk about their feelings from moment to moment. But when we think about it as a clinical thing, we really think about something that lasts for, say, at least 2 weeks. Pretty much every day, people may feel depressed, down, sad, tearful. But in addition to that, oftentimes people have physical changes. There may be changes in their sleep patterns. There may be changes in their appetite. They may feel physically very slowed down, or they may feel very anxious.
So they would be very good warning signs if people are consistently having trouble sleeping at night or feeling a drastic change in appetite.
Right, and again, something that persists over a period of time rather than just feeling down about a particular bad thing that happens to you.
How does the disorder manifest itself in patients who are considered subclinical?
Again, there may be changes in these kind of areas. And typically with what we think of the winter form of SAD, people really lose energy. That's the number one sort of indicator of this. And particularly sometime in the fall or winter months on a fairly regular basis, they just drag themselves out of bed. They may have some sleep changes, oftentimes sleeping much more than they would in the summertime. Their appetite in many cases would increase. Oftentimes people with winter SAD find themselves really cramming in a lot of carbohydrates, especially in later hours of the day. And so those are kinds of changes that many people may notice to some degree, but it may not really incapacitate them. Whereas for some people, it may interfere with going to work, it may interfere with school, it may disrupt their social life, or cause them other kinds of real problems.
Does it ever get to the point where it's actually life-threatening?
Well, I would say so far it seems to be relatively rarely, and one of the reasons for that may be that people do have some inkling that when spring comes they will feel better. So the problem of hopelessness, which is such a big contributor to suicidal kinds of feelings and behavior, isn't such a big factor typically for folks with SAD. It's much less common for people with SAD to have such a severe depression that they would end up in the hospital also, although that does happen sometimes.
So the main threat to a person's life would be from suicide then?
Typically with depressive disorder, that's the thing that would be of greatest concern. Mm-hmm.
Now, while we're on that subject, I think an awful lot of people still feel that there is something about anyone who has a mental illness that is dangerous, that people who have some sort of mental illness should not be gone near, should be treated with kid gloves. And I think it's very unfortunate that a lot of mental patients are stigmatized in that fashion. People who have depression, are they generally dangerous to other people, or if they're dangerous at all, only to themselves?
Well, there's nothing about depression per se that tends to make people dangerous towards others. It may be true that for some people, when they get depressed, they may get more irritable. And people who have trouble controlling their behavior when they're irritable could conceivably do something, but that's really not a part of depression per se. And if anything, yes, people with depression might be more prone to harm themselves. But really, one of the important things I think about the whole seasonal depression phenomenon has been to remind us that there are things, even cycles of nature, that can profoundly affect people's mood, people's energy and sense of well-being, and it's clearly not their fault. So I've had many folks, because this disorder has relatively recently come to our attention, it's been in the last 10 years really that the research has been done, and so there are many people who had sought treatment previously of many, many forms, people who were in psychotherapy for years and may have at times felt really bad about themselves, that even though they worked so hard, tried so hard to get their life together, along would come October and they would feel terrible again. And so the understanding that there was something in the physical environment that appeared to be involved in this, and that it wasn't some sign of weakness on their part, really has been a big boost to many people psychologically, just to relieve them of that burden.
Is there any belief that this seasonal affective disorder is related in any way to some of these cyclical or circadian patterns that animals follow as far as hibernation, that type of thing? Have there been any studies that show there is a connection or a link or a similarity even, or would it be faulty to make that analogy?
It's been an important analogy. I mean, it's really guided people's thinking. I would say in many ways technically it's not correct, that there's many things that hibernating animals do. The hibernation process physiologically is certainly different than what actually happens in SAD. But there is certainly some suspicion that what it is that regulates internal rhythms, which is profoundly influenced by the number of hours of light in a day, has some relationship to the physiology of SAD. And particularly this whole recent wave of research was in part made possible by a discovery in the late 1970s that very bright light, much brighter than people typically get indoors, had an effect on a certain hormone which is called melatonin and which is secreted only at night and is known in many animals to be involved in regulating seasonal rhythms, whether it's hibernation or rhythms of reproduction, for instance, animals that mate only in a certain time of year. So when people realized that bright light could affect melatonin secretion, they started to think that perhaps that was the reason that it would have an effect on depressed folks, that there was something about that particular hormone, for instance, that might be abnormally regulated in folks with SAD.
Are people who already suffer from more commonly known type of depression, such as bipolar depression or manic depression, are they more inclined to be diagnosed with SAD, or is there really little relationship?
Well, unfortunately, we just don't have good information about that yet. One of the things...
Relatively new field that you're studying.
Sure.
Yes.
One of the things that happened is that people who've studied SAD wanted to make sure that they were really studying sort of the pure thing. And so in the research centers, typically, we've included folks in the studies who don't have any other kind of disorder to complicate sort of the understanding of what's going on. Consequently, there isn't a lot that's known. I could say, clinically speaking, I have seen many patients for whom there seems to be a coincidence. They may have an ongoing depression or manic depressive bipolar illness that goes on through the year, and then have this special added problem with depression in the wintertime.
But you would be speaking from your own experience on that, and there really aren't any studies, and you would probably be more inclined to see that particular group of people anyway. To begin with, so those are the people that you would be... in
the sense that because they're probably in treatment,
yes.
Right, they may more easily have access to that kind of resource.
You started mentioning light therapy. Could you explain what light therapy is and the mechanism, if it's known, by which light therapy works?
Sure. Light therapy involves having people exposed to bright light, and again, much brighter than ordinary room light, for some period of hours in the course of every day during most of the season when they're vulnerable to depression. And it seems that it works through the eye, that it may, in fact, affect the centers in the brain that regulate circadian or 24-hour body rhythms. But the exact mechanism really is not known. And it was it was guided by hypotheses, but so far the data haven't clearly supported any one of them, so we're still
But basically what the data does support is that for certain persons, if they are exposed to bright light, this will ease some of what they might commonly call the winter blues.
Definitely so. It's been very, very successful.
It sounds very simple. Can patients, or should patients, sit in front of a lamp and administer this to themselves?
Well, I suggest people really approach it cautiously. Light seems like such an innocuous thing, but in fact, there are some wavelengths of light that can be dangerous. You know, we all know not to stare at the sun, for instance, or we know that there are certain kinds of apparatus that we shouldn't look at because it can harm the eye, and not all light bulbs are the same. So, first of all, it's important to get something that will work, and secondly, it's important to get something that's safe. So I really suggest that people go through a mental health professional or research center and make sure that they get some equipment that's really been tested for safety and for effectiveness.
But where does a person go? Let's say someone is watching the show and says, hey, I get pretty down in the winter. You know, Christmas comes along and I feel really depressed, and I usually pick up in the spring. Maybe this is something that applies to me and something I could benefit from. How would you direct them? What can they do right now or within the next few days to begin to seek treatment?
There are several centers that, fortunately, in the Boston area, we're rich in research centers. There's a facility at the Mass General Hospital. There's a facility at McLean. We, of course, have our clinic at the Brigham and Women's Hospital. And there's also a facility at Nashua, New Hampshire, that's not that far away, the Brookside Hospital. So there are a number of places where research and treatment of SAD have been going on for several years now, that are accessible in this area. And for many people, their mental health benefits and health insurance will cover some of this.
How often does a patient need this therapy?
It's something, if it works for people, typically they do each winter throughout the period of time when they're prone to be depressed. This varies from person to person. It's quite common, for instance, for people to really notice an onset around the time we change the clocks in the fall. But for some people it comes later. They may really feel okay until January and then suddenly slump. So whatever that particular season is, that's the time when they do the treatment. And for some people, just 1 or 2 weeks in some of our research studies has been sufficient to hold them for several weeks. But for other folks, they relapse really quickly when they go off the light. So it's something that we really work with the individual patient to try and come up with something that fits their physiology.
The apparatus that you use is called a light box, is that correct? Mm-hmm. Could you explain what that is exactly, or does it use standard light bulbs? Does it use the full spectrum of light? Or?
Sure. It's originally, they were trying to duplicate sunlight because they just weren't sure what it was in the spring and summer light that was helping people. And they did use what they call a full spectrum light. However, in subsequent years, we've tried tinkering with that formula and found that, in fact, ordinary cool white fluorescent tubes can help people. There are certain kinds of incandescent light bulbs that can be used. The real key is the intensity, the illuminance level of the light rather than any particular kind of bulb.
So it's the brightness rather than the type of light that seems to make a difference. Now, I would think to the average person listening to this, especially if you are an active person and you have a full-time job, you have a pretty busy schedule, the idea of sitting in front of a box that's shining light in your face for several hours a day seems to be pretty monotonous, and I think a lot of people would say, well, I'm really not that bad that I have to sit and stare at a light. Does it take that long? Do people have to sit there for long periods of time? Is there any way to shorten the process? Can it be shortened with intensity of light? How does the whole process work as far as a person doing this?
It certainly varies. I must say one of the biggest factors is just the difference in individual sensitivity. So part of it really can't be tinkered with, but it is also a function of things like the kind of light source that you're using, how you're seated in one spot, whether it's reading or eating or conversing or balancing your checkbook. Any of those things are possible. So it is true that at the moment it could, say, take anywhere from half an hour to a few hours per day. But so far I think most people have felt that the relief was really worth the period of time.
It's basically the idea of having the light in the room. It's not necessarily looking at the light directly.
It's not looking at the light directly, but in order to really get the best effect, you need to be properly positioned and so forth, and that's the kind of stuff that we really go through in a session with somebody who appears to have SAD.
The chemical serotonin, I know, is something that has been a topic of research with light therapy. Could you explain what serotonin is and how it works?
Sure. Serotonin is one of the chemicals that's used by nerve cells for communication one to another, and it's because it's found in brain cells and nerve cells, been of interest to people in the mental health area. There's been some feeling for many years that it may be related to depressive disorders, and there's also been some understanding that the way that you get more serotonin in the body may in part be affected by what you eat, that as you eat more of the building blocks of serotonin, you may actually increase production.
So that's why people's carbohydrate appetite might be increased.
Well, paradoxically, as you increase intake of carbohydrates, it can affect other processes that result in having more serotonin. So there was a time, there's been a lot of important work here in the Boston area, particularly at MIT by Judy and Richard Wertman, and their group has looked especially at the possibility that carbohydrate craving has something to do with people trying to alter their own levels of serotonin. And so because of that interest, and because of the fact, as I mentioned, that SAD patients tend to really crave carbohydrates, they became interested in this and did some studies there with drugs that affected serotonin to see if they would also be effective in treating SAD. And in fact, they were quite successful in their studies there. So that's been one of the most important pieces of evidence suggesting that serotonin may have some involvement in SAD. But again, it's something that's really still not clear.
What about antidepressant drugs as a means of boosting serotonin? Can they be used also?
Well, there are some antidepressant medications that have been designed specifically because they're known to affect serotonin. For instance, some of the more recently well-known antidepressant drugs. It's been something that's been a recent trend, but not exclusively so. It appears that for many people with SAD, antidepressant drugs of various kinds can be effective, not only the kind that affect serotonin, but also some of the, what you might say, older, more established antidepressant medications.
So what would be the point then of a person sitting in front of a light box for 3 to 4 hours if they can say, well, I'll just pop a pill and I'll feel better?
Sure. It's very much a question of individual taste. Many people really would rather avoid taking a medicine if they can, and for that reason I think light's been especially popular. But absolutely, there are also reasons to make other choices, and so it appears that those choices are available to many people with SAD.
Do European doctors use different therapies in treating SAD than American doctors?
There have been several research centers in Switzerland that are really based around phototherapy or using the light box. Now they're also participating in some of the studies of antidepressant medication, but there isn't anything particularly different than what's available here.
One thing that has me very curious, I've known a number of people that get very depressed in the summertime as opposed to the winter, when there seems to be a tremendous amount of light outdoors, seems to be a lot of sunshine, the days are longer, and yet this is the time of year when they really go into a slump. And I've often wondered, since you call it seasonal affective disorder and not the winter blues, if it is something that can manifest itself in the summer, and also if it does, would you say that it could possibly be a result of people actually hiding from the weather, hiding from the heat, and perhaps because it's a very hot day, staying indoors with the air conditioner and depriving themselves of sunlight? Do you see a light relationship with people who are depressed traditionally in the summer as opposed to the winter?
It's an interesting question. What happened historically was that at the National Institute of Mental Health in the Washington, D.C. area, the SAD work really got started about, as I mentioned, about 10 years ago. And they began to hear from people who had summer depression saying, hey, what about us? They initially tried some studies with light therapy, but the feeling at this point is that the people who have specific summer depression may be responding more to heat and humidity than to light, and that in fact the thing that seems to be most helpful is air conditioning or some kind of a temperature-related treatment rather than a light-related treatment. So there may be some connection in the way that the body's sort of metabolism is regulated, but it's a relatively indirect one.
It's kind of interesting also because you mentioned equatorial climates, and you said that in equatorial climates this depression doesn't quite show up as often. Correct me if I'm wrong with that. Then doesn't that, how does that relate to the heat theory that you're just mentioning? Is there a contradiction there? Or
the winter form doesn't show up as much. For instance, there was an interesting survey study on the east coast of the U.S., and they looked at New Hampshire, New York City, Maryland, and Florida. What they found was, again, roughly a quarter of the population report problems at one season or another, but which season it is depends on where you are. So for instance, for 99% of the people in New Hampshire, the problem is winter and not summer, whereas when you get down to Florida, it's a much smaller proportion who have trouble with the winter and a much larger proportion who have trouble in the summertime. So this summer depression phenomenon seems to be largely in the U.S. a kind of sunbelt disorder
How about that?
Rather than being something that we experience a great deal up here.
So people in equatorial climates then also have a seasonal rhythm, but they tend to get more depressed in the summer. Is that what you're saying?
That seems to be the case, And there was a report actually from India some years ago, which, because not only are they in a different latitude, but they have a different climate pattern. It isn't the kind of seasons that we think of with a hot summer and a medium fall and spring and a cold winter. It's a very different pattern, and as a result, they seem to have a different form of seasonal depression. That is, some people still seem to be responding to the climate at particular seasons, but it doesn't necessarily take the form of a winter thing or a summer thing. It may be a rainy season thing or different forms of seasonal responses.
Is treatment expensive? Suppose I can hear people sitting out there saying, well, it's all very nice, but you know, if sitting in front of a lamp won't help me, and I have to go out and buy an expensive light box, or I have to see a psychologist or a psychiatrist once a week, my pocketbook just can't take that, so I'll just suffer through the blues.
Sure.
Is it expensive treatment usually?
There is a range of costs. You know, as any healthcare professional, I'm troubled by the difficulty that's raised for people in having access to care because of finances, and that has an impact here as everywhere else.
And that's not just with seasonal affective disorder, that's across the range with mental health. Yeah.
Because seasonal affective disorder is relatively newly discovered, and light treatment is still considered by some people to be not proven. It's not always reimbursed by people's health care plans. So it's something that, depending on your circumstances, if for some people everything would be covered by insurance, for others not. There are some possibilities of participating in research as a way of getting a chance to try the treatment at a lesser cost. And for instance, at the Brigham, we have services available through our psychiatry clinic as well as the SAD clinic per se, and so there may be a sliding scale that would be applied through the psychiatry clinic at our hospital. So there are various ways that people can sort of try to get something affordable, and there definitely is a range. The apparatus itself, there are some kinds of devices that you can use which may cost $50. And there are some reasons that, you know, there's some obvious advantages to some of the more expensive products, or they wouldn't be successful. But there are a range of options. The important thing is that people really work with somebody who knows the area to find out what's safe, because it's really not worth the few bucks that you might save to either buy something that doesn't work or buy something that's harmful. So it's really important for people to try to find some way to manage getting a consultation with somebody who's informed.
Once a person has purchased a light box, let's say they go for the Cadillac and they make the $300 to $500 investment, how carefully do they need to be monitored? Do they still need to see a professional for advice on a weekly basis or a monthly basis, or is it from that point on a do-it-yourself?
I would say certainly we don't follow people on a weekly basis. The typical situation is that somebody would come in for a fairly lengthy initial evaluation and a discussion of the procedures, and that there would be maybe 1 or 2 brief follow-ups after that. But once people know how they're going to respond, it tends to be a routine that doesn't require a great deal of follow-up. I do, with my patients, also suggest that they have follow-ups with their eye doctor. That is, that this is still an experimental kind of treatment, and although every indication is that it's very safe, and we don't have any reports of people being harmed or their eyes being harmed, it's something that needs to be followed and research needs to be done. And so I do think that that's a very important piece of this safety concern.
Dr. Anderson, will you briefly describe the facilities that are available at Brigham and Women's Clinic to treat seasonal affective disorder?
Sure. We have the Seasonal Affective Disorders Clinic, and there are offices both on Route 9. near the Chestnut Hill area, and also at the main hospital of the Brigham. If people were interested in an appointment, they could just call us there. And also, as I mentioned, through the psychiatry clinic at the Brigham and Women's Hospital, it's also possible. And for some people, for instance, with base state insurance or other plans, that would be the way to go. So that kind of information would also be available through our receptionist.
There are specific hours
people by appointment.
And how does one arrange an appointment? Call the receptionist there at the clinic at Brigham and Women's?
Sure, at 278-0540.
Okay, we'll put those numbers on the screen so that people
or the psychiatry clinic is 732-6753, and they just need to make it clear that they're interested in an evaluation for SAD.
Okay, in summing up here, Dr. Anderson, I think that one point that you want to stress is that this is not something that people should do at home on their own. Would you agree with that? This is something that if people feel they are affected by this disorder, they should seek professional help and take it from there. Is that correct?
Sure. There are a lot of folks who I'm sure are eager to experiment with this, and as I say, it sounds pretty innocuous and for the most part has been very safe. But we want to make sure that this continues to be a good news kind of a story, and that people get something that's effective, that they do get some success for the money that they invest, and that it's a safe thing. So yes, I really suggest consulting with a mental health professional about it.
Okay, well, Dr. Anderson, thank you very much for being with us today. I think you've given some valuable information. I hope that some people in our audience will take the information to heart and stop feeling so sad in the winter and do something about it. Great. So thank you again very much for being with us today. For Burlington Magazine, this is Tony Inverso. Hi, I'm Tony Inverso. Burlington Magazine is a program that's dedicated to bringing practical information to Burlington residents. If you have information that you would like to share with the community, or you have a particular topic that you would like to see us pursue on Burlington Magazine, please drop us a line. The address is BCAT, care of Burlington Magazine, Post Office Box 740, Burlington, Mass. We look forward to hearing your comments and suggestions. Again, the address is BCAT, care of Burlington Magazine, Post Office Box 740, Burlington, Mass.